Welcome to the Rehab Remix.
Where we break down the hottest topics in ortho and neuro PT to help you elevate your clinical game. We're your hosts, Dr. Lauren Tighe
And Dr. Lauren Young, bringing you practical insights straight from the evidence to your earbuds. What time it is, the mic is on, the vibes are right, and we're diving back in. This is where the research meets real life and voices from the field bring it all into focus. Put your headphones on. It's time to remix. So in part one, we explored the big picture, what migraines are, the different ways they can present, some common myths, and why PTs haven't traditionally been recognized as providers in this space. Now in part two, we're going to get more hands-on with Dr. Jimmy Pang about the actual treatment and evaluation of patients with migraines, strategies that make a difference for patients, and advice for students or new grads who want to step into this area of practice with confidence. So my first question to kind of roll us into this part of our conversation is, Jimmy, what are some common triggers or lifestyle factors that you educate patients about? So things that you continuously or consistently see that you really think are important to educate your patients on.
First thing we have to do when we see a migraine patient is we need to give them some form of empowerment. So the truth is, when a migraine patient comes to see you and they already have a migraine diagnosis, they've probably already been subject to a lot of bad advice. So we need to handle that first, I think. So I think we need to be clear on what it is we do for migraines. A lot of people who get diagnosed with migraine, the advice they get is for a lot of avoiding things, eliminating triggers, right? You can't do this, you can't do that, right? It leaves people feeling really hopeless. So what is the goal of effective treatment? So the goal of effective treatment isn't to teach them to avoid all these things. Our goal of effective treatment is to raise their threshold so that typically triggers that might trigger an attack will not in the future. So I think that's a really big piece that we want to get across. And then in terms of the triggers for migraine and lifestyle advice, I think the biggest one I really harp on is quality sleep and stress management. So I think if we can really hone down on those, you're going to have a lot more wiggle room for triggers that might cause an attack. So I think let's just do a quick example. So one common trigger that a lot of people complain about, and I fall into this camp as well, is weather changes. So barometric weather changes. If a storm's coming, or if one day it's a little more dreary, oftentimes a lot of people will experience an increased rate of migraine attacks, right? But I think there's a difference between if that happens in conditions where you aren't stressed and you're getting good sleep, the chance of that triggering an attack is much less versus if you're running on 2 hours of sleep and you're working 5 jobs or whatever. Then when that trigger comes along, it's going to be a lot easier for it to tip you over the edge. So I think general life advice, regular exercise, stress, and sleep. I think if we can really hone down on those things, it gives us a lot more room to work.
I always find it interesting how a lot of different conditions that we see as clinicians comes back to sleep. Sleep, daily movement, nutrition, and stress. And I think sometimes we take it for granted. And even just as clinicians, I mean, as I get older, I just realize how important sleep is, how important quality sleep is, no less. And so I think that is just something that is constantly said, but a lot of us don't really put it into practice.
Yeah. Good sleep hygiene. I take my sleep very seriously. I don't bring my phone into my bedroom. It stays outside. I've broken up with my phone. And then I have blackout curtains. I keep I keep my room cold when I go to sleep. So the whole 9 yards. Yeah. So I think as PTs, we got to practice what we preach.
The American College of Lifestyle Medicine has like 6 pillars of lifestyle medicine, essentially, and it's sleep is one of them. Nutrition, like you said, Dr. Tighe. Some of the other more obscure ones are like social connection and decreasing substance abuse as well. And I think someone who has migraines that are disabling, it's really difficult to have that social connection because you're trying to live and manage in a world that's all of these things. So like you said, Dr. Tighe, those 6 pillars are foundational for anything. And exercise is one of those pillars. But I've tried to explain this, and I think I've said it before on this podcast. If we are only looking at exercise and we're not looking at anything else, like we are missing a huge opportunity to practice within the full scope of what our DPT license can do, or our therapy license. If you're an occupational therapist or a speech therapist, being able to ask these questions, because exercise isn't going to cut it if, you're you're running on 2 hours of sleep and stressed to the max. Like, great, do however many reps of whatever. It's not going to matter because your
Hmm.
foundation isn't solid. So, Jimmy, when you're looking at these folks, what does a typical plan of care look like? Like, how long are these patients with you? And then how are you measuring their success? If there are specific outcome measures, we would love to hear them.
So most migraine patients are going to present with headache. Not all of them do, believe it or not. But my go-to is the headache impact test 6. So it's a really quick outcome measure. It's only 6 questions, and it's going to give you an idea of how much disability they're experiencing with their headache. Naturally, if you have someone with vestibular migraine, then that's when your balance outcome measures are going to be relevant, as well as the questionnaires such as the Dizziness Handicap Index. And then going based off of that, a typical plan of care, I think it's going to depend on the severity. I think if it's very cervicogenic in nature, then I'm thinking more along like 6 weeks, 6 weeks to really hone down on the cervical range of motion, cervical stability, things like that. But these are also chronic cases. So people are probably going to want tune-ups, and it depends on how much care a person wants. Some people are very independent. They don't need the accountability, right? Some people don't
Mm.
need a therapist to keep them accountable, things like that. Some of them, they really need that and they want to come in and see you more frequently. I think if we're looking at something like a vestibular migraine, that I would say anywhere between 6 to 12 weeks. Because we have to remember with vestibular migraine, it's not like a vestibular hypofunction where they're coming in and something is purely vestibular. It's really not true in the case of migraine. No migraine patient is going to come in where it's like, it's just this one thing. It's always a lot of things going on at once. Being able to determine what's going to be the biggest driver, what's going to give you your biggest bang for the buck, that's definitely what you want to focus on. So yeah, in terms of outcomes, I'm trying to think if there's anything I haven't covered. The headache impact test, patient-specific functional scale, I think is also really good. Yeah, now that's a quick one that anyone can do. Those are all great ways to track progress.
When you are looking at, like, because the migraine, and correct me if I'm wrong, like, it is an event that happens. It could be 2 hours, it could be 2 days. So when someone is actively experiencing a migraine, do you want to treat within that active period? Are you really letting that go down and getting them in when they're not in an active migraine?
Yeah, so I think if you're a PT and you're seeing a migraine patient, most of them have chronic migraine, so their presentation is not so episodic. So, well, let's get to the attack first. So when they're in the throes of an attack, that is not really the time for you to be doing your therapeutic interventions. That really is when you want to be working more in terms of pain modulation, pain modulation techniques that we might have under your belt. So if I'm seeing someone and they're having an actual attack at the time, that's kind of where I rip out the manual therapy, right? More passive treatments. What we really want to do is we want to be invariably every migraine patient is going to have another attack at some point. So as therapists, what we want to do is we want them to be prepared. So with my migraine patients, I like to create what I call a rescue kit, and it's going to be different for everybody. So, we can use sensory distractions. Some people really like things like essential oils. Like I said, I think pharmaceuticals play a role. So definitely making sure people have their abortives on hand. Basically, we want a kit so that when they run into this road bump, they're able to handle it. They're mentally prepared for it, and we don't let it throw them off too much. So I think where it gets interesting with migraine, though, is migraine has these attacks, but I think what people don't realize is these attacks, they kind of leave scars. So, if someone's having a lot of attacks and it's really not controlled well, it can very well result in things like convergence insufficiency. I see that all the time. I think that's a hugely underutilized assessment in migraine care. So I just had a patient the other week. She's got migraine, and then when I do the near point of convergence, bringing the pencil in closer, we'll see one eye kind of slip out and then it comes back in into the convergence. So already I'm seeing convergence insufficiency in somebody with a migraine disorder. So these people present with a lot of them will present with very obvious neurological signs. And I think that's where migraine care gets really interesting.
This is like drawing so many parallels as you talk. I was going through the concussion CPG earlier today, and it's drawing so many parallels to like you're using the same examination and evaluation tools, but you're interpreting the information differently and using it in a different manner. But these are all subsets of concussion, right? People can present with more of a cervicogenic problem, more of an autonomic problem, more of a vestibulo-ocular problem. So that's just so fascinating because you said this earlier in part one, where you said if you're good at, vestibular, you're probably halfway there. And I thought to myself, yeah, maybe I am more equipped to do this than what I thought. But like if I saw somebody with a migraine on my schedule, I would panic and I would be like sending you messages upon messages and on Instagram trying to be like, help. But it's very true because, we have the tools. If you're treating neurologic diagnoses, this is a neurologic diagnosis. It just presents in a different way. I think something that I'm always concerned of is like, am I going to make it worse? Right? Like, if I'm doing something, am I going to make their migraine worse? Which, like you said, maybe if they're actively in a migraine, you just tone it down, passive techniques, and then, move from there. But this has all been so helpful. I appreciate your insight. Advice would you give to new grads or clinicians who have never been in this space, who don't really know where to start? Like, did you take some continuing education courses? Do you have certifications that helped you? Like, what advice would you give them to be able to treat this population better?
I think a good place to start is actually, like you mentioned, the concussion CPGs. I actually think that's an amazing place to start. These are both central disorders, concussion and migraine. They have different pathophysiology, but the presentation can be very similar. The only exception maybe is with migraine is you have to think about, I mean, lifestyle is obviously important with concussion, but I think with migraine, it becomes extra important. So when I think about a concussion, the pathophysiology, I'm thinking of like, the myelin sheath gets damaged, so we're looking at a system that has all these frayed wires, right? Migraine is a little different. Migraine is like we have all these symptoms going on, but it's just a hypersensitive brain and the gain is like turned to 15, the gain is turned really high. So we're always trying to think of ways that we can reduce the amount of gain that the sensitivity in their brain. And so I think when it comes to migraine, if you want to go into migraine more, a lot of people probably already have the clinical skills to deal with this. So then it just comes to understanding migraine pathology, understanding how lifestyle plays into migraine care, and then also understanding when you need to refer out and what kind of people, yeah, you want on the team.
I love that from the standpoint of just our like profession. And I think that's the beautiful thing about our profession is that like you can start out in like some sort of niche population, right? So like Dr. Young said, as you were speaking, I was like, wow, this is all the similar things that I do to like treat sport concussions or assess sport concussions. And I think sometimes as clinicians, we feel like we just like pigeonhole ourselves into like one niche population. And we don't really realize we have the skill set and the knowledge to venture off into something else in addition to concussion. So like you said, starting if you're interested from a standpoint of like treating migraines, starting with the concussion CPGs. And I think that's one of the really neat parts about our profession is there are a lot of different ways to intertwine it versus like siloing everything. So I just absolutely love that. Dr. Young, before I ask our closing question, do you have any other questions that you want to ask Jimmy?
No, I just want to talk through like a little bit of the neuroanatomy piece of this. And Jimmy, I think that
Oh
as
no.
you've seen, well, I was going to say, I feel like
That's how I feel.
been talking about it a lot. Y'all leave me alone. Cranial nerve 5 has a really big impact in migraine, which is why you get some of that facial pain can be a portion of this. It does a little bit of the sensory on like the dura mater on the brain, which again is like where that headache piece comes in. So part of it is like regulated within the brainstem because that's where our cell bodies for cranial nerves lie. And but then all these other strange, I'm going to quote, symptoms are because the cranial nerve 5 runs through, the brain and has sensory pieces in the brain. I don't know if there's anything, Jimmy, you want to like add to that neuroanatomy piece, but when I have the opportunity, I always am going to drop some neuro nuggets.
No, I'm actually glad you brought that up. So, like you mentioned, the trigeminal nerve has a lot of innervations in the face, which is why we typically hear people with migraine have pain on one side of the face and typically behind the eye, right? But it's also important to realize that the trigeminal nerve also has autonomic functions. So in migraine patients, you're going to also see things like sinus congestion, eye tearing, ptosis. I actually present with ptosis when it gets bad. And I can't remember the exact numbers, but there's like a ridiculous percentage of people who get diagnosed with sinus headaches. They're actually starting to suspect that it's actually migraine pathology in origin. And what's really cool about the trigeminal nerve in migraine is there's something called the trigeminocervical complex. So it's like this ganglion of nerves and, it has connections to the trigeminal nerve, but it also has connections with the sensory afferents from C1 and C2. So that's where the cervicogenic piece really comes in, because if we can modulate the excitability of that, ganglion from the neck, we have the potential to decrease the severity of the symptoms that they're experiencing from the trigeminal innervation in the face. It's actually also something I think a lot about is also facial rehab. That's also a really exciting field. And people with migraine do present with facial weakness. So that's something that I'm actively working on, trying to learn a little bit more about that. But it just goes to show migraine, it's a never-ending rabbit hole. There's so many different ways that you go about it, so many different things that you have to think about. So it doesn't matter how good you are, you're always going to run into something that stumps you, and then that's just going to be your driver to get better at your job.
Well, Jimmy, your patients are lucky to have you.
I agree. I literally just feel like my brain is going like this listening to you guys like talk about neuro. I'm like, love it. So, Jimmy, our last question, which we always like to ask our guests, is what is your personal rehab remix? So, like a unique habit, a hack, or a mindset that you use every day or regularly?
My motto is one day at a time. That's really helped me a lot, both with my personal health and with running my own business. Just take it one step at a time, and yeah, think in terms of small incremental steps to getting towards your goal. Don't get ahead of yourself.
I love that. So before we wrap up today, could you let our listeners know where they can find you, whether that's on socials, over the internet, however, and just so they can follow along with your journey and what you're doing?
Yeah, absolutely. So if you're a little more curious about migraine, you're welcome to check out my migraine page on my website. It's going to be pangphysicaltherapy.com, PANG physicaltherapy.com. And then you can also follow me on Instagram at Pang Physical Therapy. My mobile practice is based in San Diego. I just moved here 6 months ago. So if you are in the San Diego area and you're just looking to connect with other healthcare providers, don't hesitate to reach out. I'd love to hear from you. And as for anybody who's listening to this, if you have an interest in migraine, definitely just shoot me a message on Instagram. I'm happy to talk. I'd really like to see more people get involved in this space. So always happy to be a resource to anybody.
Jimmy posts like the most amazing like stories and like clinical tidbits. He's like so fun to follow. I learned so much from him. So Jimmy, we really appreciate you being on and sharing your journey and sharing your knowledge with us. Be sure to sign up for our newsletter linked in the show notes. You can find me, Dr. Young, on Instagram at NeuroElitePT. And Dr. Tighe, where can they find you?
Instagram as well at LTigheDPT. Thanks for tuning in to the Rehab Remix, where you listen in and level up. We'll see you next time.